Afternoon, it's November the 4th, 2021. I am Matthew Holt, founder and publisher of THCB at Baltiboy on Twitter, and it is 1 o'clock West Coast, 4 p.m. East Coast, time for THCB Gang on a Thursday afternoon. Fun lineup today. A couple of people who haven't been on for a long time, so I'm looking forward to this. We have from Richmond, Virginia, and Health Coast Hilarious podcasts, Casey Quinlan, Mighty Casey on the Twitters. Robin Farmanfarmaian, I haven't seen her for ages, but now her schedule's changed. She's back again. Speaker, author, entrepreneur, and everything, and all-round superstar. Kim Bellard, regular contributor to THCB, who's been writing about all kinds of interesting stuff that I don't understand, like quantum computing on THCB lately. And Anish Koka, cardiologist and provocateur. So here is the gang for the day. We're up and running. Hopefully you're either watching on the YouTubes or will soon be listening to this on the podcast. And let's figure out what everyone has been up to and ask the people who haven't been here for a while where they've been. So can I, but I'll also ask what we've been looking at this week. So I'm going to start with you, Kim, to tell us what you've been looking at.
Well, like we were talking about before the broadcast started, the elections on Tuesday. So either the voters in Virginia, New Jersey, and New York and other places were very upset with the Democrats for not getting the drug pricing parts right, or Medicare expansion, or maybe it was the Paid Family Leave Act, or that other people were more upset with critical race theory and transgender athletes in schools. And of the two, I think I know the answer to that, and I'm sure that Casey will kick in on that. But it's very discouraging how the 22 elections are going to be based on issues that are not really that's central to our country.
It's not been the case in all elections in America for the last 30. I won't go into that part. All right, Robin. Great to have you back on THCB Gang. Where have you been, and what have you been up to, and what have you been doing? And then tell us what you've been thinking, looking at the last couple of weeks.
So I have been finishing my fourth book. It's called.
I do believe you are muted.
You are muted. Yes. Can you unmute?
I can hear.
You can.
Now
you guys can.
You're good now. You're good now. We'll
Perfect.
cut this out in post-production, maybe.
We'll clean it up in post.
So I have been finishing writing my fourth book, which is Leveraging AI to Democratize Healthcare, Shifting Care from the Clinic to the Point of the Patient. And I've also been working on a virtual reality radiology reading room, which is really, really cool, putting the reading room into VR. But the things that I'm really excited about that happened both this week. One, Merck, their new antiviral pill for COVID cleared in the UK. This is a game changer when it comes to the coronavirus, having a pill as an antiviral. The second thing that happened, and it just came out a couple of days ago, was Medicare's new 2022 physician fee schedule. And guess what's on it? Remote therapeutic monitoring. So this is really cool because it's a subsection essentially of what we call RPM, remote patient monitoring. And it's not the physiological stuff that is already reimbursed by Medicare, things like your vital sign data. The remote therapeutic monitoring is interesting because it takes into account things like when you use your inhaler, did you take your medication, which is not currently under the remote physiological monitoring codes. So this is huge and just another way to shift healthcare to the point of the patient.
Very exciting. We'll dive into both of those in a minute. Actually, in all three of those, including the radio. We don't have Sarab Jar on this week, so we can't have the radiologist telling us about the reading room, but we can all fake being radiologists because you just sit in the dark and look at pictures. I mean, we've been doing that all for 18 months, right? Anyway, fantastic. All right, Casey, what have you been looking at this week? You were on last week, so you want to know.
Well, I haven't. Not too much. I live in Virginia, so yeah, there was that. Although I voted in October because I'd just like to get things done and get them out of the way and go on with my life. So I did. Anyway, today landed on my screens. Apparently the FDA has taken some tax dollars and used them for something worthwhile, as far as I'm concerned. I'd love to see how much they paid for this, but there's a very clear, easy to understand, in plain English, targeted at the average human video about cybersecurity and connected medical devices that the FDA just put out this week that is really good. And it's right around 4 minutes. It's captioned, so it's accessible. And it does talk very simply about being cyber secure as a user of a connected medical device, if you are one, a person who uses one of those. And I'm fascinated by it because at least people are now talking about cybersecurity at the consumer or patient level, which until now hasn't quite been a thing. But as anybody here knows, I'm certainly aware of, because of online privacy and health data and the way that patients have been bought and sold, their data have been bought and sold, and yes, the patients too, by big tech in ways that the patient doesn't know about. And it's buried in the terms of service that we're all like, who has time to scroll through all this crap? Just give me the thing. And meanwhile, you signed away your, all of your rights to your data in that public conversation, or even not so public conversation. And so that was a big thing. And then also on the healthcare blog, Grace Cordovano's piece that I think it went up yesterday, or I saw it yesterday, about the health conference, HLTH, that I've never been to because who can afford that? And then also there are no patients here and they wouldn't really pay attention to me, so why go? And
I would have paid attention to you had you gone, but go on.
Well, no, well, if it's somebody that knows me, obviously they know. Yeah,
I have some commentary about that.
But also, I'm really loud. But anyway, no, I've just never really seen the value from my perspective, because they still have that old school patients included model, which is we are all patients, which for me just gets a doish, shut up, and like that. So they don't really need me there. But anyway, so the FDA cybersecurity awareness and Grace's article on the healthcare blog. And then also Joe Manchin is telling porkies again, but boy, that just means it's Thursday. So.
All right. Okay. Anish, it's been a while since we had you on. Welcome back. What have you been looking at and thinking about recently? I suppose you have clinical stuff as well as you have some vague interest in politics and who knows what else.
Yeah, so so I'm a boring clinician, so I'm buried on a daily basis by the problems of how to solve access problems in healthcare and get the drugs that patients can't get because this insurance doesn't cover, that insurance doesn't cover. So that's always a kind of a full-time job. On the other side of things, it's been kind of really interesting to watch in the last 2, 3, 4 weeks, kind of, maybe this is culminating with what happened in the Virginia race, the New Jersey race, in terms of what some of the fallout may be from what's been 19 months of kind of public health, kind of basically running point on so many things that they're not normally advising on, right? I mean, you can imagine, it's amazing to think now versus say 20 months ago, what public health kind of controls, right? Public health controls what restaurants you go to. It controls if you can go into a restaurant. It controls whether your kids can go to school, whether the schools are open, if your kids are masked, which small businesses can be open, and how they can be open, staffing issues. I mean, it's just an endless stream of things that public health has now been responsible for. And I'll be interested to hear from the panel whether or not there's been some frustration in some nonpartisan frustration in large swaths of the public that results in kind of, normally blue voting states kind of, perhaps expressing that frustration at in the voting booth.
Yeah.
I would have said that public health was always responsible for those things. It's just that we didn't have the public health crisis as it called for it.
Well, there is that, right? But you got to agree with Anish on one thing. I mean, so it's clearly true that if you have had kids in a school, now you may almost certainly have never heard of critical race theory before Fox News told you about it earlier this year, and you certainly couldn't explain it if you had heard of it. But going beyond that, there's certainly a deep concern amongst parents with school kids, like speaking as one, that they sat in your house for a long time. Now, I happen to have an au pair girl and I'm relatively privileged and blah, blah, blah. But even people I know who are knowledge workers who are sitting at home with two people on two family members, mum and dad usually, on a computer doing their Zoom calls, the kids, high school age or less than that, doing their Zoom calls. That's not a good situation for anybody to run for a long time. And if you got the feeling that your local school board, and Exhibit A, and this is not the one I'm in Marin County, but the one in San Francisco, that basically said we're closing down for the whole last year and we're not going to bother even pretending to open up, but we will change the name of the schools. I get that partisan, non-partisan, believe Fox News, AstroTurf, not AstroTurf, whatever you think of it. I get there is underlying, can we not go back to freaking normal? And now we've got the vaccine, whatever, can't we do that? So yes, while there's been a ton of extremism on the school debate, I get that there's a basic underlying thing.
Yeah, so that's what I'm saying. I wonder whether, there's a lot of oxygen taken up by the whole debate on critical race theory and whatnot in schools. But I wonder if it's maybe simpler than that. Maybe it's the fact that the school closures for as long as they were. Look, I'm sitting in Philadelphia, right, which is right next to New York City, and I remember vividly early March of 2020 when pandemonium was breaking loose up in New York City, and colleagues and stuff, kind of all these incredible stories that I never thought would be alive to hear about, right? And it's happening 90 miles north of me or whatnot. I emailed the schools, my school district, and said, guys, you have to really consider shutting down. I got a polite email back that day saying, well, talking about, there's schools or places that are safe spaces for kids. They're also free where kids get lunches.
Right.
And, I remember writing back right away saying, no, I understand. I'm not saying schools aren't important for those things, but you have to understand there's a respiratory virus that we have no idea how exactly fatal it is, that's circulating in large numbers. The SHID is hitting the fan in New York City, and I really think that regardless of that, you got to figure out a way to get kids lunches and stuff at home. And so I wrote a letter to the school district saying, hey, I think we need to. Seems like we need to shut down. It was like full blown panic amongst not just healthcare professionals but everyone. But I did not. I was not writing an email to keep schools closed for 18 months. My goodness. At some point, I did not understand how you could continue this over and over. And it really did seem to be that once it became, to Kim's point about public health was always in control, you just didn't know it. I don't think public health ever quite understood the level of control they would be able to exert over the entire economy until this actually happened. And it's like schools were closed, and you know what? People were okay because people were terrified. And
but let's also not directly associate school boards with public health. They're related, but school boards were making decisions that were not necessarily at the dictate of public health. So public health certainly did a lot of things, but school boards do a lot of strange things for a lot of strange reasons, and let's not give ourselves otherwise.
Right.
The other thing to think about school boards is that so schools are about as locally controlled as anything in the U.S. The school boards are elected by the local people, and everything's locally controlled. And what we're seeing now, though, is people don't like that. They still want to make their own decisions about their own kids. It's like saying to the state legislature, to Congress, we don't want you guys to be in control. We want to make up our own minds about everything. And we don't live in a form of government like that. There are forms of government like that, but they're not the one that we live in. So it's a radical thing. And when they get down to I don't want my kids reading books that accurately portray the history of our country, that's a problem.
Well, setting that aside, just a simple thing, like if there's a community that is okay, so, there's certain Catholic, just as an example, there's certain Catholic schools that are okay, say 6 months into the pandemic. Actually, kids didn't start to be masked until relatively recently. I remember last summer taking my kid to soccer, and kids are running around playing with no masks, and so this kind of progressed over time. And those dictates in terms of, local school board members were not coming up with, we must mask the kids. No, that came from CDC, local health authorities. Like the public health apparatus would make a recommendation, it would filter down. So then suddenly you have the Montgomery County, where I am, Department of Health or whatnot, would then put out a dictate, and the local Catholic school, which isn't publicly funded, cannot go against that, right? So I think my belief is that some level of frustration relates to just that. At some level, parents, and that's just talking about like masks or and playing soccer and stuff. I think at some level, parents realize that they're not in control of very much. That there's a small group of folks that are controlling these very large decisions, and I mean, again, I don't know what you folks think. I mean, is it a reasonable thing to have schools closed for 19 months, especially when we learned in the course of the first 6 months that schools were and kids were relatively low risk there, and there were different strategies that we could employ. Take the more vulnerable elderly folks that were teaching, and you can maybe isolate them, socially distance them, not in school, maybe have them at home, and there were things to do to kind of put schools. I'm just giving one example, schools, but that was a hot button issue for many liberal friends as well as conservative friends that were just aghast and really felt like the teachers unions were kind of doing what they wanted. That was things that were best for the teachers union, but not what was best for the kids. And so a lot of these decisions felt very political and under the sway of large influencers, and in this context, that influencer was the teachers union.
I think that. Sorry, Casey.
One of the reasons that the Virginia gubernatorial election turned out the way it did yesterday or Tuesday, or 2 days ago, Tuesday. Anyway, but one of the reasons that it turned out the way it did was that on the Democratic side, there was just a whole lot of shouting about, if you elect this other, this guy that's running on the Republican ticket, you're voting for Trump. And it's like, okay. And then the Republican himself, who never distanced himself from any of the anti-Biden, whether or not Biden is legitimately the president, he never distanced himself from that message. But he did say clearly, one of the things he ran on was that parents should make the decisions about what happens in the schools for their children, which I don't know how much actual control his administration is going to give parents over schools, but I think that there was a lot of pent up frustration on both sides of the aisle over exactly what Anish was just talking about. That people felt really frustrated that rules seemed to be coming from somewhere else, and it was making the lives of parents difficult. And it did appear as though kids were less prone to getting COVID infections. That changed somewhat as the vaccination rate went up, and then you started seeing more children getting the disease. But I think that was happening anyway, and I think that there was a legit fear on the part of school personnel, of which teachers are part, certainly, but there's also a lot of other people, cafeteria workers, custodial staff, et cetera, who live in living situations where perhaps an elder parent was living with them and was at a higher risk of COVID, or they had an immune compromised spouse, or there could have been any one of a number of things that had people thinking, I don't really want to be in a congregate setting with a whole bunch of other humans breathing on each other. And the mask rules were, always people, throwing things if someone said there was a mask mandate. And I think that the schools were forced into a decision initially by the fact that this was happening, a pandemic, but then schools stayed closed all of the academic year 20 into 21 because the vaccine rollout happened, but then there was the vaccine resistance piece, and that's another story. But there just wasn't a speedy enough rollout to everybody that it was able, we were able to open schools again. And then now, we're in the 2021 into 2022 academic year, everybody's scrambling to catch up. And there's still all of these fistfights over vaccines or not, masks or not. And it's like, can we all, no one wants to trust the science, because depending on who you listen to, it sounds like science is saying different things. I know better, but if you're just an average human out there, you're confused AF about what to believe or who to believe. And, the authority of the authorities has been undermined by every rando on the internet gets to have a website and talk about their thing, their truth. And so, we're in a post-truth age. So welcome to the party, pal.
Well, I'm interested in hearing Casey and Kim. Do you feel like Anthony Fauci, do you feel like his you feel like he has been undermined? And I'm curious what you all think about why that is.
I think that the problem with, or, like the ways that, Fauci proved to be a liar, these kind of headlines that pop up from time to time, is that science is built on uncertainty. And, it's like you stumble into something and it's like, oh, well, we proved this. Okay,
right. So,
now let's take this apart.
How do mandates fit with uncertainty though, right? So, meaning, okay, so like the 5 to 11-year-old child vaccination, right? I am thrilled that the FDA approved the 5 to 11-year-old the vaccines for the 5 to 11-year-olds. It was a Pfizer, it's a Pfizer product. It's the 10 microgram dose, which is 1/3 the dose of the adult. It was based on a 2,500 to 4,000 patient trial that showed safety in that place. So, and there was, depending on what you read about the VRB PAC presentation by the FDA to the FDA, there are 94 kids that have died in that age group, 5 to 11. There are 28 million 5 to 11-year-olds. 94 kids have died up to now. And if we can certainly prevent even one mortality moving forward with these vaccines, that's a wonderful thing. That being said, there's there's uncertainty that's impregnated in that, right? Meaning, does the approval to allow kids who are 5 to 11 get it? You cannot otherwise. I cannot prescribe it. No pediatrician can prescribe it unless the FDA approves it. That approval, though, is being converted into a mandate. California, I think the San Francisco Department of Health has already done that. And the question is, do you want to take a 4,000 strong trial of kids, and then do you want to give that mRNA vaccine to 28 million children? That raises a lot of questions, right? The rate of myocarditis that I brought up about 2 months ago when I was last here, right? The rate of myocarditis that's been signaled since April of 2021 from the initial Israeli data, because they had a mass vaccination campaign. The rate of myocarditis there was 1 in 5,000, right? The rate of myocarditis could be, 1 in 20,000 based on some of the Pfizer data. But the point is that you're never going to get to a real understanding of the risks of the drug to kids if you do a 4,000 patient trial that's already underneath, it's not designed to catch those type of adverse events. And should we have asked for a larger trial, or should we just, approve it, because it's important to prove it, because there are some high-risk kids that are overweight have been shown to be at higher risk of ending up severely ill in the hospital. There's a big-time discrepancy in low socioeconomic status kids. Black children, Hispanic children, make up like 70% of the kids that end up being hospitalized. Now, I may be off on that number, but a significant majority are Black, Hispanic, low SES kids. So it's a wonderful thing that this was made available, right? But then to see the San Francisco Department of Health, just the other, last week, then convert that to, no, this is now mandatory. You cannot participate in daily life, cannot send your kid to school unless you give your kid the vaccine. 40% of kids, according to the CDC a month ago, already have recovered from COVID. So you'd be talking about giving recovered kids who you don't really know if that the vaccine is benefiting them. Now they're going to be mandated for that. By the way, in the trial, they excluded the kids that were vaccinated, right? So, I say excluded the kids that had recovered. So, there's a reason.
I can cut to the chase on this.
There's a reason for uncertainty.
Andrew Wakefield needs to be burned in public at the stake, and then we can maybe move on. As far as mandates go, I'm not in favor of mandates for kids, but I understand why government officials are thinking that they're something we need. I don't necessarily agree. I do think that the parents should be able to decide whether or not their kid gets the vaccine. But in the world in which we currently live, unless we burn Andrew Wakefield at the stake in public, we're stuck with this.
But here's this is a serious issue, right? Because the politics of this rolls on very quickly. I mean, whether it's critical race theory or whatever on the school control thing versus, as I think Anish and I agree, which is pretty rare, that we have, frustration. But on the childhood vaccines, and we'll get off this topic after I'm done, because we said we wouldn't talk about this and we're already at 20.
Here we are.
But on the childhood vaccines, I mean, it's got converted from, I think there was reasonable questions about the myocarditis thing. I hope I pronounced that rightly. And how that's going to play out with kids. We don't know much about that in the the under 12s, right? That seems to be older, young adults seems to be the 16 plus, the 24 plus seems to be the sweet spot, or if that's such a thing for males.
Yeah, and the lower dose may mean that
it may help, and hopefully it works. And then we don't really know about long COVID in kids, and there is a little bit of data about the prevalence, about the factor of previous infection in the Medicare population being a good thing, and maybe not having to take so much of the vaccine. But as I said, it's not crystal clear. But in Florida, as far as I can see, and elsewhere, this is getting translated into we're not having any vaccine mandates for kids anywhere. And we're going to end up with where the reason we have a vaccine mandate for kids for measles and rubella and all that stuff in California is because we had really big pockets of parents being anti-vaxxers not taking it. Go back to Andrew Wakefield. And you end up with what we had, which was like an outbreak of measles at Disneyland and, stuff that shouldn't happen in a modern society happening. So anyway, we should stop talking about this. I really appreciate Anish's explanation of what's going on in that. I assume you're okay with me about I've got to call my pediatrician's office back to set up my kid's vaccine. But my kids who are terrified of the flu vaccine really want to take this. They have internalized for whatever reason at school with a family that getting the vaccine is going to enable them to have more freedom. They're okay wearing a mask. They've been doing it happily at school they were at a camp at the school for 18 months, and I don't think kids are as pissed off with that as the parents pretend they are, who use now as a political prop. But we're seeing all this stuff get used as a political prop, and I don't know if it's ever going to win, because this thing isn't going to go away completely, but we'll see. Right, so let's move on to I'm declaring victory and going home on that topic, and let's move on. I want to dive into what Robin was talking about, because Robin, you've been patiently waiting, but I would love to hear more about what you've been up to in this issue around Medicare expanding to, hang on, did I get this right? Remote therapeutic monitoring. Is that correct?
Yes.
Okay. So can you explain for people who don't know, because what's going on in the world of remote patient monitoring and the codes for that and how that is playing out? And there's been solid investment around that. And then what the difference is remote therapeutic monitoring and how that's going to play out. And let's start talking about what we think this might mean for, say, getting care closer to the home.
So it's incredibly exciting. So remote patient monitoring is the ability to monitor patients in their daily environment. That's kind of the umbrella term. When you are specifically talking about CMS Medicare, when you say the words RPM, it actually means remote physiological monitoring. Now, this is an important distinction when I'm talking about RPM versus RTM, remote therapeutic monitoring, because remote physiological monitoring means actual hardcore data. What is their blood pressure? What is their pulse oximetry? What is their sleep? And all of that. Whereas remote therapeutic monitoring are things like patient-reported outcomes. How frequently is someone using their inhaler and at what time of day? That type of thing. And so this really opens it up for a lot of new companies. This is a massive opportunity space because no one had been thinking about remote therapeutic monitoring up until this point, right? So all of a sudden we can have a lot more companies. The other major difference is RPM, the remote physiological monitoring, can only be done by clinicians, right? So very specific people on the healthcare team. Remote therapeutic monitoring, on the other hand, can be done by assistants of things like physical therapists. Now, it was originally thought of for muscle scare, the MSK world, physical therapy and that kind of thing, PT, but it really can expand outside of that to things like medication, right? So watching the patient take their pill. Now, while this doesn't exist on the market yet, I am guessing in the next couple of years, we're going to see a lot more of the cameras that are verifying and validating when somebody actually physically takes a pill and swallows it, right? And that right there, that's reimbursable now.
So that's very interesting. So just to play back, in the last couple of weeks, we've seen several companies raise either big rounds or get bought. Best Buy actually bought a company, a Scottish company called Current Health, for I think
600 million or something.
So
was it?
A number more than the rest of us have got put together, right?
Yes.
And there has been a lot. I've run into a lot of startups, a lot of people discussing. I don't know, Anish, if they've come to bang on your door because high blood pressure and stuff is certainly one of the areas that there are companies now In fact, I'm talking to another, not you, but there's another cardiologist who's trying to set up a company doing exactly this sort of monitoring, managing people with high blood pressure and heart failure and what have you. And there is now a lot of interest in, can we do monitoring of patients while they're sitting at home? There is a bunch of interesting stuff going on here. One is that there's about, I think you have to actually check up on them. Somebody, clinical, whether it can be the company or the doctor working with the company, has to check up with them 20 to 40 minutes a week. And there's some boxes to be checked doing that. The other thing is that, and I think you can make about 150 to 100 to $200 off Medicare per patient for doing that. And usually the business model is that the clinician's practice, the physician practice gets some, the company gets some, and presumably the company does the work and the physician gets extra money. That's what's been sold anyway. And then the other thing is I keep on running to companies who say, we have XYZ monitoring device and we're going to get the full $200 or whatever. But a lot of those patients, of course, need plenty of different types of monitoring. It's unclear whether it's, if you have diabetes, you might also have heart failure. You might, how do they splice up the money, right? So there's some issues there. And I don't, and then the last piece is there was a similar CPT code which Medicare paid for called chronic care management, which was in the same zone, which was rolled out a few years ago. And a bunch of companies were set up around that, and a couple of them really imploded badly because they couldn't get the patients to sign up or the physicians to sign up, or there were a bunch of reasons for that. So this is an interesting area. And the last thing I'll say, Robin, is there are a couple of companies I know already who are trying to do sort of compliance management for medication, who are using cameras to take, you take a photo. One of them is called Wealth. They happen to be a company that Health 2.0 had in one of its programs for New York City, where you they put $50 or $100 in your bank account, and you took a photo of yourself taking the pill. And every time you didn't take the photo and send it up to you, they took $10, $5 out of your bank account. It was like the wealth. It was the risk. It was the behavioral economics thing that people hate losing money.
It's brilliant.
That's awesome. It sounds clever, and they raise.
I love it.
Whatever they're doing. But
I will say that I test drove one of those. I can't remember who it was because it was a few years ago, and their back end technology wise was terrible. And half the time the photo didn't load. And I'm like, nope, you're not soup yet.
Yeah, well, I mean, that all this new stuff's going to have those issues, right? So you have technology issues, market issues, but it does sound as though what Robin's talking about, you've got a whole, do you know what the fee is going to be for the remote therapeutic monitoring?
No, I haven't looked at the math behind it. It's probably going to be similar to the existing RPM codes, right? So it's going to be, hundreds of dollars a month if you are able to tap into all of them.
Yeah.
But they do
Robin,
things like the setting up of the patient. So the educational part, just like RPM does, which is a really big deal as well.
So years ago, there was a concern that, if the clinicians had all this data, that they had a liability, that, if something bad happened and they did not respond in real time or near real time, that they could be sued. Has that issue been resolved or ameliorated in any way?
I do not know. I do know the very first time that American Well rolled out its program with its in-house contracted doctors doing online care, they actually bought an entire malpractice insurance policy for anybody on their system. I don't know if that kind of thing's happening here. Who knows? I actually want to ask, Anish, should someone come and try to sell you one of these things?
Oh yeah, all the time.
and have you bought one? And if not, why not? You're turning down free money according to all the PowerPoints I see.
I do have an RPM remote physiologic monitoring program with someone, actually a local cardiologist who set up a system. So kind of supporting them, and they have a good product, and they send us reports on a monthly basis. We get alerts if the blood pressures are high, and it's really great. I interestingly, I don't know, I cut it off at, I think I enrolled 300 patients, and I could enroll a lot more, but I'm a little nervous whenever these new fee schedules come out, and I'm always nervous at setting up the practice to be too dependent on one one code, right? Because the next year, if they cut it 50%, then suddenly I'm scrambling to do something. So and here's the interesting thing. Of course, guess what? And I have I'm still one of the few folks that takes all insurances as well as no insurance, and of course, but of course, the folks that are most liable to do these things are the folks that need it the least,
Yeah, that's
the ones that are relatively tech savvy, Bluetooth doesn't scare them, the app and stuff. And they're relatively youngish, I have some older patients, but, so it's still the folks, I'm a little dubious that it's going to have the size of effect we kind of think it is, which is what Medicare and CMS is thinking, and being like, oh, if we just, because it really, in order for me to really be on top of the patients that are really hard, you know what I do for those patients that are really, really tough, right? I work with pharmacies that like fill the pills by day, and patients get like a package, like on this day they'll get this. So it's really simple. Open up the blister packet and put it in, right? So the patient doesn't have to like go through and like fill his own pill box, right? So I work with a pharmacy that does that for me, for my patients that that have some challenges. And then the other thing is I just see them, I bring them in, some patients I bring in on a weekly basis. Simple things like there's a great new diabetes injectable that's once a week that allows you to minimize how much insulin you take. Insulin long-term, insulin is life-saving, but the less insulin you can be on, the better it is for you long-term, right? And there are these new medicines that they're called GLP-1 agonists that you inject, and they're once a week. They're pretty amazing. Insurance, if they pay for them, or we get samples from the pharmacies, some pharmaceutical companies very happy we'll bring patients in on a weekly basis because patients can't figure out how to inject it. They lose it and on the subway on the way home and stuff. So I don't know. I think that's what we do, at least in my practice, to try to, have a safety net around these folks to keep them out of the hospital. I literally will see this group of 30, 40, 50 patients on a weekly basis to try to keep their blood sugars down in the hospital. That I don't know that RPM is gonna work for those patients.
Well, maybe not for those patients, but yeah. There's a couple of golden rules, right? CMS sets this gold standard in healthcare. As CMS goes, we can expect to see the private payers follow, right? And it just takes a few years. But it's really just one more puzzle piece of this entire ecosystem, shifting care from the clinic to the point of the patient, which really, again, goes back to democratizing healthcare to people who can't get into a doctor every week, right? They live 4 hours from the nearest town or what have you. Yeah. And so this can be a game changer to where we get to the point of literally ambient computing in healthcare, in the home.
You know me, I'm a provocateur as I'm introduced as, and I think there's a tremendous amount of promise. And I think there's been a tremendous amount of good use cases, positive use cases here. And there's certainly, I can give you just off the top of my head, a list of a number of folks that have benefited greatly from this type of remote stuff and taking care to the patient and whatnot. So no question about that.
The thing I worry about with the fee schedules is, the monitoring and the monitoring and analysis of the data is going to get incredibly cheap, as technology gets really better. But we don't have a very good track record of the fee schedules, reflecting that the service being provided is getting easier and easier and cheaper to do. We keep the fee schedule the same. The apocryphal story here is, when cataract surgery went from, actual surgery to lasers, ophthalmologists suddenly could crank a lot of people through and they got very wealthy as a result. I hope that doesn't happen with remote monitoring. I hope somebody's paying attention to the technology that enables it and how cheap that's getting.
Well, so I think there's a couple of things going on here. And one of them is what Anish said, right, is that there are multiple different ways to manage the care of very sick people, right? And we don't know exactly the best. What we do know is, in general, it's not done very well, right, across the system. So I think we agree with that. And there's a lot of, and this flips into another argument which is happening right now, which is the issue of Medicare Advantage and upcoding for plans and providers of Medicare Advantage. I was actually on a couple of webinars on the Health Tech Nerds Slack channel. That's a great newsletter, Kevin O'Leary's newsletter. He had Don Berwick and Rich Grigor-Fillan talking about essentially how they felt that initially the payers, and to some extent the payer-owned providers, were essentially sticking it to the taxpayer by doing this illegitimate upcoding. We've talked about that many times on THCBGang. Jeff Goldsmith has complained about people coming to his house and trying to sort of make him be sicker than he is in the codes. But what CMS has also said, and they've come out, under the new regime, right? Chiquiti Brix-LaSure and others have come out and said what we're going to be doing is narrowing down the number of sort of experimental value-based care, alternate payment models we're doing, and trying to expand those. But eventually, eventually get everybody, over time, get everybody off fee for service. And adding a payment to a CPT code, right, for remote patient monitoring or whatever the hell it is, like, is kind of not the same concept as doing, how do you do value-based care, which is the best way to look after these people? Because in the end, the goal is not to get remote patient monitoring to a particular patient, right? The goal is for whatever the best way that a care organization or patient can be looked after by that organization. That's what we should be doing. And maybe it's they're coming to Anish's office every week, and that is the best answer, right? So the problem is, I suspect, I don't know, Anish, how we pay you or your organization to figure out, do it the best way rather than do all these random things where we're adding up, can we pay you a bit more for this? And this goes back to the telehealth thing, right? Where when people got paid equivalent for telehealth and they couldn't do it any other way because you couldn't come to your office because back to our earlier conversation, the public health department told you couldn't come in, right? then that's great. You're doing telehealth, and then we cut the reimbursement on telehealth and you go back to seeing people in person. What was actually the best way to do it? I mean, that's not clear.
Yeah. I mean, value-based care, I'm not a huge fan of it. It sounds great in theory. I was a huge fan of it. I love the ACA parts of it that moved us away from fee-for-service to that. But it nobody can figure it out because value-based care means you gotta come up with some metrics. And those metrics, if they're outcome-based, right? Then you see what happens. I mean, look at what's happening in hospitals, right? Hospitals have entire teams of people that run around to make sure they're coding everyone. They're saying just right, but we know there's plenty of examples of upcoding that's happening to make patients seem sicker than they are, so that they can say that, okay, our outcomes based on how sick they are, expected versus observed mortality, expected, whatever. So the value-based stuff, I don't know that it really works well. So I'm still left with a little bit of a puzzle about what to do, because I agree with Kim is that it's not a great system, because ultimately it results in a lot of rent seeking and a lot of wealth transfer from the citizen taxpayer treasury to some highfalutin tech bros in wherever, exactly. So I don't know what the right answer is. I mean, Kim's making a strong case for markets entering healthcare because they'll get the price right. It'll be easier in terms of getting the price right.
But the problem is that I've witnessed this. I've lived through it on repeat. Is that the number that happens every year, which is how much the U.S. and we're talking about the U.S. system here, how much the U.S. spends on healthcare every year as a ginormous blob of humans paying for healthcare in some way or another. Yeah. And basically, people started pearl clutching when it was just above 2 trillion. Well, we're now perilously close. I think we could probably say it is 4 trillion now. And it's risen that much in a time when we've all been pearl clutching and trying really hard to fix it. So I'm just going to point at all of the legacy players in this game who are on the receiving end. Well, no, and I don't just mean providers, Anish. I'm literally not talking necessarily about doctors here, although sure, there are probably plenty of MDs or people with letters after their name that are on big receiving ends of big chunks of this money. But the status quo is fighting like dogs to hold on to the status quo of whatever their slice is. They want, go innovate those other guys, because we're down to the bone here. We can't do anything. But, and then in complexity is confusion, and the payers are minting coin off of that, because the payment model that we're playing with here is so complex that, you ask any provider, what's the cost on this? And they don't know, because
I totally agree, Casey. This is why we should eliminate Medicare.
That's not the direction I'd go in necessarily, but I don't see how anyone who is on the providing care, or, other than the low end, federally qualified health center, et cetera, clinic type thing, that nobody gets turned away. I don't see any insurers in the classic model going broke right now. I mean, if you look at any of their balance sheets or in on any of their earnings calls, they're doing just fine. 10. And, even the two that have actually tried to do managed care and managed to pull it off relatively well, Kaiser and Geisinger, they're constantly, having to battle to, keep market share. And, and I would love it if Kaiser would come into Richmond, the city where I live, just because it would certainly be entertaining to watch everyone else deal with that. But they won't. And so that's been an interesting, but I just, the fee for service is a problem. Medicare as fee for service is a problem, but I will say as a patient, a person who is, yes, admittedly over 65, when I aged into Medicare, I did not go for Medicare Advantage because I can read policies and I recognize the narrow network trap doors that I was standing on as someone who does travel. I mean, not as much as I used to because hello, pandemic. And then, oh yeah, by the way, stage 4 cancer. So there's other, things I'm dealing with now, but I still will stick with straight up Medicare because the managed network thing that most Medicare, well, all Medicare Advantage plans run on, well, it's a trap door that I'm standing on.
So let me come back to Robin for a second here, because there's something else going on which we haven't quite talked about, right? Which is that there's also a locus of control and power shift to patients who want to do stuff for themselves at home, and who've been in many cases fighting, right, to move stuff along. Now, go back to the point you raised right at the start, Casey. Grace Colavano's piece on THCB this week about the health conference. Now, blowing my own trumpet for 5 seconds. At Health 2.0, we had patients invited, patients on the stage. We found money to pay for patients to come, et cetera, and I think you were on the stage a couple of times, Casey. Robin, you've been on the stage in Tokyo or somewhere anyway. But, and I didn't see enough of that at Health, so Grace is dead right. But we are talking about moving things so that, maybe it's not the 30 patients that Anish is better off seeing in his office because of whatever, their personal circumstances. But we are talking about moving a lot of stuff to the home and for patients to do more essential safe self-management with coaching. So just this week, for example, there was a company funded called WellLinks, which I didn't even know, I was unaware this was something that could be fixed at home, which is essentially doing a Livongo type home coaching plus device management for COPD. Right, Anish is doing something, this remote patient monitor with 300 patients in it. I don't know how this is effective. I don't know how much this is helping patients to become empowered and take over their own care. We have on the gang today 2 very empowered patients who are very, very tough about it. But I mean, I don't think either Casey or Robin, you're particularly typical. So I'm wondering, Robin, how much do you think this is going to help tip it towards not making everyone like you, but making everyone closer?
Closer to the craziness. It may or may not. What it really is getting the buy-in from the key people inside of healthcare besides the patients, right? Because those who control the flow of money have all the power. So it's getting the buy-in from the physicians, from the hospital systems, from the health systems, and from the major payers. And that trickles down into being able to empower the patients. I usually, when I give my keynotes, I'll do 4,000 doctors or 1,000 hospital CTOs, because talking about patient empowerment to patients isn't that helpful. But talking about patient empowerment to 4,000 doctors and teaching them the different tools that they can use with their patients to teach their patients on how to do this. Now that actually makes a big difference. And so these things are just, again, small puzzle pieces in the overall puzzle of the ecosystem shifting to care to the point of the patient.
Do you think it's, to poke you on that, Casey, you've been doing this a while. Robin, you've been talking about this for a while, written several books. We'll get on to your new book in a second, I promise. But, I don't know how much that this is drifting through to, we're seeing a lot of excitement, a lot of money being thrown in crazy directions in Silicon Valley and elsewhere to companies who are, promising to sort of support with coaching and everywhere else. We clearly have a massive shortage of providers, we're going back to sort of to top of the doctors, nurses, people disappearing into the night, out of hospitals, etc. maybe this can be replaced with clever technology and, you know, essentially cheaper people, and then the patient doing it themselves. But how much do you think we're getting there in terms of you hearing about patients actually being moved onto these systems by their clinicians? I mean, is Anish an outlier for having 300 patients in this thing?
The two giant use cases that are really shifting, and it's been shifting for about 5 years now, are the IV infusions out of the hospital-based infusion clinics and into the home. You know, I did this about 6 years ago with my Remicade, and I've now saved my payer over $1 million. $1 million over 5 years.
Did they send you a check? We had this on last week. JL was talking
Jean-Luc.
Jean-Luc was talking about, as a doctor, how he had stopped his dad who had I forget what it was, going to a hospital. He said, I saved United Healthcare $1 million. I never got a check or a thank you.
Or even a thank you.
That's not the way healthcare works.
You should be sending them a bill, Robin.
That's not the way healthcare works.
Shared savings and all that, right?
So we're seeing the infusions being shifted. Now, why it's so important to link that to things like RTM and RPM is because, like Remicade, it's 25% murine mouse protein. So there is a risk of going into severe shock and dying, right? So I have, you know, an anaphylaxis kit essentially on hand that my nurse could give me. But my drug actually isn't even anywhere near as dangerous as some of, say, the oncology drugs. And that's why I'm working with Alacrity Care on remote patient monitoring, specifically around oncology drugs, because they are such dangerous drugs. But the second thing is we're seeing dialysis moving into the home. And that's huge. Dialysis right now is controlled by 2 major companies, about 90% of the market. Only one of those companies are actually a manufacturer and now have an in-home device for patients to be able to do that. And so those 2 things, and they're 2 of the most expensive parts of being in a hospital as an outpatient, have fully shifted, you know, into the home. And now we're going into the world of oncology and shifting that too.
Yeah, no, it's interesting.
And I'll weigh in.
Casey, sorry.
I'll weigh in from the cancer patient side and say that there's been some actual media as opposed to ads, but you know, media about cancer doesn't necessarily mean classic chemo anymore. And I'm an example of that because you know, my first round with early stage breast cancer, I went through classic chemo, but this time, you know, same oncologist, different staging. I'm now stage 4, but I'm taking oral medication that costs whoa dang, and because I'm savvy, I know how to get it from its manufacturer free, because even with you know, Medicare coverage, because of the trapdoors in the donut hole in Part D, it would be like whoa dang. But I mean, the thing is though, that I get hours of my life back because I'm not pinned to a chair. Robin knows what I'm talking about. Pinned to a chair in some infusion center, you know, have an uptake of this thing, and then, you know, go through the cycle again in 3 weeks or you know, whatever. But the issue is the cost, both of the classic chemo and then also now the oral meds available for certain types of cancer. The cost is so insane that you know, the issue for some patients is you'd be better off doing classic chemo because you have to go and sit there and the billing and the payers and whatever, everybody's happy except maybe you, but you don't really count here because you're just the object going by on the conveyor belt. But you know, the payment models for all of this is just crazy. And then, you know, after I got out of the hospital, when I was Wesley, mostly dead from Princess Bride in June, much better now. But I wanted home health for longer than I got it afterwards, before and after. But, you know, no, I, you know, still had to, you know, go to wherever because of the rules for the payment models. And it's nuts.
No, I mean, I think that goes to the point that Anish was making earlier, which is that, you know, we're not quite sure how to do value-based care or what the outcomes are, and the rest of it we're constrained.
No, everybody's trying to hold on to their piece of the $4 trillion.
We're constrained by the Medicare fee schedule, which is, don't forget, based on the Blue Cross fee schedule from 1936 and hasn't really advanced on since then. I think that's why Anish wants to abolish Medicare. I don't think he wants to put you out on the street and make you pay 25 grand a month for your drug.
Well, you know me, I'd figure it out.
I'm not sure. We'll figure that. All right. Okay, we have like 4 minutes left. We have to do our roundup, but I do want to give Robin like 2 minutes to tell us what the book about. We started with the book about AI, and we never came back to it. I said we get there, and we're going to get there. So, Robin, quick, what's the AI? Tell us the name of the book again. When you're done with it, what it's about. Go.
So it's called Leveraging AI to Democratize Healthcare: The Shift in Care from the Clinic to the Point of the Patient. And so it's really all about things like vocal biomarkers and AI voice technology and digital therapeutics and imaging analysis and all of the things that we were just talking about, the RPM, the RTM, all of the cool devices going into the home, allowing patients to be in control, patient as CEO, and be able to take advantage of some of these technologies. And these same technologies that are expensive and brand new here over the next 5 to 10, even 20 years are going to be able to really change the equation for people in places like the developing world or that are 4 hours away from their nearest clinic.
That's great. So quickly, when's the book out? Are you done?
2022. So it's coming out spring 2022. It's done. It's just
you're done, but it's not going to be out, and you'll be on the speaking circuit if there is such a thing in spring 22 to talk about that. And then the one question there is, how much for that, all the stuff you talked about, how much does AI mattered? So how much does AI matter for those? Is AI important for that? Because most of the trends you're talking about could happen. I mean, there may be some AI in Anish's remote patient monitoring. It's probably just come back and saying, hey, this person had, a week of high blood pressure above 130 over 90 or whatever it is. And let's send a text message. I mean, AI and machine learning get talked about so much and so much buzzword. Does it matter, or is it like nice to have?
Specifically in AI voice technology and vocal biomarkers, which we are going to see explode over the next 5 years. It's such an interesting area of healthcare, but that is completely based on AI, with things like virtual reality that we're seeing, stroke care and that kind of thing in the home. That, of course, is fully based on artificial intelligence. So AI really does have a massive place in a lot of this shift in care. And of course, the digital therapeutics, that's CBT based on their, algorithms that they've written. Yeah, it helps personalize and do precision medicine for the patient.
So I mean, smack down about AI. Well done. I like it. And the good news is we'll all be in the Mark Zuckerberg healthcare system. And what only if
God, no. Oh God, no. How did he get in here?
Kim wrote an article 2 weeks ago about the metaverse and how it's going to work in healthcare. And and there is serious people talking about pain control and psychotherapy and stuff in VR, and clearly
VR's been proven to be effective in some small trials. So
and now you have the world's third richest guy and fourth biggest company deciding that in order to get out from all the other stuff they've been doing to the world, they're going to concentrate on this new thing called the metaverse. We'll see. All right, that's great. Okay, we're right at the end of the show. I just want to really quickly go around and ask everyone what they are looking at for the next couple of weeks, what they got their eye on, and we will start with you, Kim.
Well, I'm hoping that this will prove to be infrastructure week finally, so that
I've been waiting for that since 2016.
I don't really have much hopes for the Build Back Better, but for God's sakes, just pass the infrastructure bill.
We'll see. All right, Casey.
Well, I have been having conversations with various ones about something that they're looking to shift in healthcare, artificial intelligence, to something that they're calling decision intelligence. And that's decisions, because we all have to make decisions, patients do, doctors do, et cetera, that would be better to frame this as something that drives decision intelligence. In other words, how can we take all the data that we have and how do we capture it on an ongoing basis and turn it into more intelligent decisions? So stay tuned for updates on that.
Fantastic. Anish, what have you got your eye on?
I have my eye on more patients tomorrow and next week.
But that's such a work. We're going to prove that on this scale again.
I'll just say that I'll just not so much a forward. I'm not as interesting as everyone else on this panel, but I'll just say that I think we just need to have a laser focus. Echoing what Kim's saying in terms of the cataract surgery history, in terms of reimbursement and how folks are making a mint when technology lowered in price. The Philadelphia school budget is $3.2 billion. That's almost $20,000 closer to $20,000 per student per year. Clearly, if you go to any Philadelphia school and you look at outcomes, you look at the buildings, you look at what teachers are paid, there's a lot of money and it's not getting to the patient. to the kids. The same thing is happening, I really think, in healthcare, or where you have a ton of money being outlaid to help in the interest of helping patients, and somewhere in between there's it's being sucked up by lots and lots of interests. My profession, my colleagues of mine we're not blameless in all of that as well, of course, but I think we have to have a laser focus on when we make these outlays, when we introduce a new code, when we give Mark Zuckerberg the ability to bill CMS eventually. Like, what we really need a mechanism in place to say, okay, is this working? Is the stuff getting to the patient? If it's not, we need to kind of eliminate things. Otherwise, we're in for a bad scene.
Absolutely. Robin.
So I'm watching Merck's new antiviral. I'm really excited to see this and see how long it's going to take the US now to clear it, at least with emergency use authorization.
All right, fantastic. So you have that was a whirlwind hour we just spent talking about a whole bunch of interesting different stuff, and hopefully this worked. Yet again, I'm having problems with the weird sharing thing that is not working on Zoom. I'm blaming somebody.
Oh, it's Zoom.
We're blaming Zoom.
It's Zoom.
Hopefully, there we go. That looks better. Now you can see. So you have been enjoying the conversation and brickbatting between Casey Quinlan from Richmond, Virginia, Robin Farmanfarmaian from Palo Alto, California, Kim Bellard, all the way from the Midwest and the wilds of Cincinnati, and Anish Koka from Philadelphia, which we just learned is only 90 miles from New York City. Who knew that these things could be quite close? That was THCB Gang for today, November the 4th, 2021. Thanks for watching the video or listening on the podcast. I'm your host, Matthew Holt at Boy on Twitter. Look forward to seeing you next week, which will be, my math